Everybody, thanks so much for the opportunity to moderate such a great session. I'm going to start with some intros for our panel. The first is Dr. Joan Luby, who is the Samuel and May S. Ludwig Professor of Child Psychiatry at Washington University. She earned her medical degree from Wayne State University and completed her residency in psychiatry and fellowship in child psychiatry at Stanford University. She is currently the founder and director at WashU for the School of Medicine Early Emotional Development Program, which focuses on the study and treatment of mood disorders and preschool-aged children. Joan has so many outstanding honors, it will make me feel really badly about myself in social comparison if I read them all. So I'm going to go ahead and move on to highlighting our second panelist, who is Arielle Sheftall, who is an associate professor at the University of Rochester Medical Center in the Department of Psychiatry in Rochester, New York, and the Director of Academic Affairs for the Diversity, Inclusion, Culture, and Equity Board. She earned her PhD in Human Development and Family Studies from Ohio University. Dr. Sheftall is also outstandingly impressive. I'll just mention that she is a member of the Congressional Black Caucus Emergency Task Force that continues to examine risk factors, practice, and policy recommendations necessary to decrease suicidal behavior among Black youth, and as a subject matter expert for SAMHSA, the Office of Minority Health, and the American Foundation for Suicide Prevention, focusing on mental health promotion and suicide prevention for Black youth. I'm excited to also present Dr. David Brent, who is a distinguished professor and endowed chair in suicide studies and faculty in epidemiology, psychiatry, pediatrics, and clinical and translational science at the University of Pittsburgh Medical Center. He received his undergraduate ed at Penn State, graduated from Jefferson Medical College of Thomas Jefferson University. He's trained in pediatrics at the University of Colorado, at UPMC Western Psych, and completed his master's in Psych Epi at the University of Pittsburgh School of Public Health. I'm excited that he's going to hopefully talk about two of his major research programs, which is the STAR, Services for Teens at Risk program, as well as an NIMH-funded Advanced Center on Services. And last but certainly not least is Dr. Richard Liu, who I'm really excited to introduce as well. Richard was one of my first postbacks, but he recovered from that traumatic experience to go on and do amazing work, and now is an associate professor at Harvard Medical School. He's a licensed clinical psychologist and the director of suicide research in the Division of Child and Adolescent Psychiatry at Mass General, and the director of the Big Data Studies in the Depression Clinical and Research Program. He received his PhD from psychology from Temple University, and he has gone on to do amazing, amazing things that would take me the rest of the hour if I told you all of the great things all of our panelists have done. Thank you so much for joining. I'm really excited to hear your talks, and we're going to start with Dr. Joan Luby.
Great. So I think I'm just going to sort of give you my talk in a narrative since we have so little time. And I guess I will start by saying that I'm kind of an accidental suicide researcher because I've been researching early childhood depression for about 30 years. And in our first study of early childhood depression, we didn't really come across much suicidality, and we didn't expect to. But the way I got into suicide research is that in our next study of preschool depression, which was a much larger sample, and we recruited that sample a little bit later in time, we noticed that a lot of children were endorsing suicidal thoughts, and parents were reporting behaviors. And we realized that we needed to look deeper into this. One of the questions, so really what I'm focused on is expressions of suicidality in children between the ages of 3 and 7. And I think for context, of course, most people would assume children under the age of 7 don't express suicidality, or they don't, they're not in danger of killing themselves. And the reaction to having children express these thoughts sort of come in two different categories. One is that people discount it, or they think children don't know what they're saying and it's really nothing to pay attention to, or they become very panicked and frightened and send children to the emergency room. So it becomes a question when young children express suicidality, what exactly does this mean? And this is what we were endeavoring to try to figure out. So first, we applied for a competitive supplement to take a look at what children understood about death. Because one of the things that happens when we look at early childhood psychopathology is there's all of these developmental questions about what is possible developmentally, cognitively, and emotionally. And so the question is, when children were expressing suicidal ideation, did they understand what they were saying, and did they understand what the permanence of death? We assessed this in our preschool depressed sample, and we in the sample are also kids with disruptive disorders without depression. And what we found is that the children who expressed suicidality had a better understanding of the finality of death than children who didn't express suicidality. So I think this kind of shoots down the idea that children are just saying this and they don't really know what they're saying. The other issue that we have stumbled upon is the idea that children who express suicidal ideation also tend to have more violent resolutions to story stem completions. So in other words, they use violence to sort of solve problems or to solve emotionally distressing events. So to me, this suggests that suicidality in early childhood is really a form of extreme emotion dysregulation. And nonetheless, that doesn't really help us answer the question of which children are in serious danger of harming themselves and which children aren't. And that's something that clearly needs to, be further studied. The other issue that we run into, and of course everyone on this panel and probably the last one also run into, is the common belief that if you ask children about suicidality, you're going to suggest to them to become suicidal. And my colleague Laura Hennenfeld, who's really developed her whole career to look at early childhood suicidality, has recently published a paper showing that this is not true, that even when we ask children repeatedly, and we did this using EMA, it does not increase their rates of suicidal ideation. So I think we can establish a few basic principles. A, it is safe to ask children about suicidality. This does not make them more suicidal. B, children who express suicidality, who are young, do seem to understand more about death, and they do also seem to have more inherent emotion dysregulation or maladaptive emotion regulation. And then this leads to the need for sort of further study of all of these issues in terms of what this means and how we screen for it and how we react to it when we see it in the world. So I think that's pretty much sums up where we stand with early childhood suicidality.
Thank you so much. Our next speaker is Dr. Arielle Sheftall.
Thank you so much for having me. I'm just going to do a very brief overview of the landscape of Black youth suicide. So no conflicts to disclose. So these are really just the past couple of years. I didn't want to give you tons and tons of data. But as you can see, when looking at Black youth 5 to 17 years of age, the most recent data is from 2023, and suicide was the fourth leading cause of death. And it's actually been up and down, depending upon how you look at Black youth suicide specifically. So when you look at it with males versus females, biological sex, and you look at 5 to 19-year-olds, what you'll see is that Black youth, specifically males, die by suicide more often than females. And in the past decade, it's actually increased about 40%. However, when you look at the female data, what we've noticed is that for Black female, 5 to 19 years of age, they've actually had a larger increase than our male youth. And then when you look at mechanism, so again, changing the age range a little bit here, 5 to 17-year-olds, what you find is that firearm is the leading mechanism at 95 deaths in 2023. However, suffocation is pretty much right after that. So 78 deaths actually occurred by suffocation or killing. And then the others are located here, drug poisoning, other. When looking at suicidal thought and actual attempts and plans, we'll actually see that unfortunately we've seen an increase in all of the high school youth that have been surveyed by the CDC. So this data is actually showing from 1991 all the way up to 2023. And what you see here is that on the bottom, we've had a 144% increase since 1991 to the most recent data. And that is for considering suicide. So actually thinking about suicide, and then you have folks that have another increase seen in the attempts, and then finally the blue line, which represents medical attention needed after an attempt has actually occurred, which signals that these attempts that are being actually attempted, I hate to use that word, but it's true, they are actually at a higher lethality than others, which again goes back to that mechanism slide. When looking at youth suicide in middle schoolers, there was actually a study done by a colleague of mine, and they looked at 7,643 Black middle school youth. They used the 2019 middle school youth risk behavior survey, which again comes from the CDC. And they looked at these states specifically because a lot of schools don't actually use the youth risk behavior survey for middle school. So these actually do pretty consistently. And what you'll see is that they looked at ideation, planning, attempt, any of the three. So they gave a yes for those kiddos that had either ideated, had a plan, or had an attempt in the past. And then also looked at kids who had ideation or a plan. And what you can see here is the data. So there were about 1 in 4 Black youth from the middle schools that had suicidal ideation. 1 in 6 who actually had a plan, a suicidal plan. And then there was 1 in 10 of the Black youth that actually had attempted suicide. And there were more female that had attempted than male. There also were more victims of cyberbullying that were presented that had experienced a suicidal ideation, planning, or an attempt. And then also Black youth who carried a weapon, that was also seen as a risk factor as well. And that gave them higher odds from experiencing suicidality overall. So that is just the landscape in a nutshell. Obviously, more research is needed in order for us to better understand not only the trends that we're seeing over time, but the reasons why we're actually seeing these trends. So without further ado, I just want to thank you all for the time. And yeah, that's my children.
Thank you so much. If, like me, you already have tons of questions that are coming from these presentations, feel free to drop them into the Q&A or into the chat, and we'll get to them after the presentations. The next one being from Dr. David Brent. David, you might still be on mute.
Okay. I just want to make sure you could see the slides.
Yes.
Okay, good. So these are my disclosures. None of it is really that relevant to this presentation, but what I wanted to talk about is 4 possible drivers for the increase in teen suicidal behavior related to cannabis, sleep, social media, and parental diseases of despair. And in order for something to be a driver, it has to be prospectively related to suicidal behavior. There has to be some biological plausibility. The risk factor itself has to be increasing, and ideally, it would be more common in the groups, the subgroups, demographic subgroups that are increasing the most quickly. And this just gives you some idea of what we're dealing with here. The teen suicide rate has gone up quite a bit, and it's gone up more rapidly in girls and boys and more rapidly in younger individuals, younger adolescents. And it's even going up in preteens. There was recently a paper that was looked at the youth serial reports from the Youth Risk Behavior Survey showing, dramatic increases in ideation and attempts. And one of the things that they found is that the rates were going up as quickly in people with relatively few risk factors as in those with a lot of risk factors. And so the question is the problem that the things that are driving the increase are things that we aren't measuring. And for example, they found that the most rapid increase was in people that were using cannabis and tobacco. But that itself, at least according to the Youth Risk Behavior Survey, has been dropping. So I don't know that you could say that that is necessarily driving the increase. Whereas things like depression, feeling you're overweight, poor sleep, being threatened, forced, those are things that have been shown to be increasing at the same time. So there was an interesting paper that Chris Hammond recently published in which he looked at the adolescent suicide rate in states that either had easy access to marijuana, medical access, or I wouldn't say no access, but no legal access. And there was a dose response relationship between access and the adolescent suicide rate. And this is biologically plausible, and prospective studies support it. But the YRBS shows a drop in the rate of cannabis use. And so I'm not really sure what to make of this, but I do think it's something that we need to consider. Sleep is another strong driver of suicidal behavior. There are tons of meta-analyses showing a relationship between suicide attempt and suicide ideation and poor sleep. And there's evidence that it's increased. And in the youth, another study from the Youth Behavior Survey showed that the rate of different types of suicidality was increasing more rapidly in kids that had insufficient sleep than in those who didn't. So I think that that's a possibility. I think there's been more heat than light in terms of social media. There's clearly a correlation between social media use and the suicide rate, but we know that that's not the same as causality. We know that there's a relationship between spending more time on devices and poor sleep. And Jess Hamilton has shown that if you have parental monitoring of screen time, that those kids have better sleep. This is a meta-analysis that Richard Liu was involved in, and I think it's a really nice example of showing that it's not so much whether or not you're using social media, but how. And some of these factors like cyberbullying and perhaps contagion or searching for suicide-related stuff, sexting, and this wasn't mentioned in this meta-analysis, but I think addictive behavior, those things tend to be driving suicidal behavior, although a lot of these studies are cross-sectional. And the other issue is that there's a confound between psychological vulnerability and use. And so, for example, there was a study from somebody, I think from Mass General, that showed that polygenic risk scores predicted about 40% of the variance in use of social media. And conversely, there's evidence that there are also that social media can be protective. And there's even something called the Papageno effect, where that people viewing stories of people recovering from suicidal crises can actually reduce their suicidal thoughts. This is just one little study that we were involved in that Jess Hamilton led. This is our intensive outpatient program for suicidal youth. And we just looked at the frequency of social media use as a predictor of recovery. And we found exactly the opposite of what we thought we were going to find, which is basically that the less kids were using social media, the worse they did. And, I don't know exactly what it means, except probably these kids were isolated and outliers, but it certainly doesn't show what most people are concerned about, that the more you use it, the worse off you're going to be. And then finally, there's the issue of diseases of despair. This is a common problem, mortality and morbidity in midlife adults, many of whom are parents. And the diseases of despair was a term coined by Case and Deaton to explain why the mortality, why the life expectancy in the U.S. has been dropping as compared to most wealthy countries. And so this are related to overdose or substance abuse, alcohol-related disease, and suicidal behavior. And this graph comes from an editorial that Jeff Bridge and I did. He developed the graph, but the red line is the adolescent suicide rate, and the blue lines are the rates of death and of despair. And we recently did a study where we found that if you link parent and child claims data, that the parents who have diseases of despair, their kids have about twice the rate of suicide attempts. Not surprising. But the effect was strongest in females age 8 to 12, which is the age group that where the suicide rate is increasing the most rapidly. And so if you look at the four candidates, sleep, I think, is a pretty strong candidate. There's a lot of plausibility. And it's also interrelated to other things that are related to risk for suicide. Cannabis, it makes sense. It's just, I just don't know that as a problem that it's increasing among adolescents, but it could be. Social media, I think there are certain aspects of social media use that are problematic. I think that it's been exaggerated, and that there are many countries with substantial social media use where the teen suicide rate is going down, like France and Germany. And I think in terms of diseases of despair, the United States is an outlier in both teen suicide and in diseases of despair, although there are countries such as Korea and Japan where the teen suicide rate's going up, and they don't have such problems. So it's not, none of these are going to be a complete explanation, but I think that they may give us some clues to prevention in the future. Thank you.
Thank you so much. Next up is Dr. Richard Liu.
All right, I hope you guys can see my slides. But thank you, Mitch, for the introduction. I'm delighted to be here and being part of this great panel. I'm going to focus today on, I'm going to focus today briefly on talking about commonalities and differences between suicide in preteens and adolescents. in terms of phenology and correlates. I believe particular value could be gained from this in a couple ways. First, adolescent suicide can serve as a contextual reference point for better understanding preteen suicide and vice versa. So, for example, are there correlates that are shared in common between preteen and teen suicide? If so, a natural question is how much about what we know about these correlates in teen suicide may generalize to preteens. And you can see how we can leverage the much larger literature on teen suicide to generate questions about suicide in preteens in this manner. This can help us in moving from identified correlates to risk factors to mechanisms of risk. Also, are there data that suggest potentially qualitative differences? And what do we know about developmental differences in preteens and teens that may inform these differences? And second, we may also be able to draw on similar age-related patterns that we might see from adjacent and larger bodies of literature to help inform our perspective on youth suicide, particularly in the case of preteen suicide, which has comparatively more modest body of literature. So first, some commonalities. When you look at psychiatric disorders across age, depression stands out, as you can see here, in its association with suicidal thoughts and attempts. In fact, among psychiatric disorders, it consistently has the largest effect. So on the left-hand panel, you see data on suicide attempts and suicide ideation in preteens from some work some colleagues and I did in 2022. And then we have a close comparison here in terms of adolescent suicide from the National Chromosome Study Adolescent Supplement that Knock and colleagues conducted in 2013. And you see consistently here that depression has the largest effect across the board when we look at psychiatric disorders. And in addition to this, there's a common view that externalizing disorders are more related to suicide in preteens, whereas depression is much more characteristic of teen suicide. And based on the available data here at present, we don't have strong evidence to support this position. Yes, ADHD is not significantly associated with suicidal thoughts and behaviors in teens, and it does have the second largest effect after depression for suicide ideation in preteens. However, not only does depression seem most strongly associated with these outcomes across the age groups, but apart from ADHD and suicide ideation, there does not appear to be much support at the moment for other externalizing disorders and suicide. In case of suicidal thoughts, the current evidence suggests a non-significant association, although it's still relatively modest. And in the case of suicidal behavior, there simply needs to be much more research done in this area for us to get a clear signal here. And where we do seek support for differences across age is in terms of social support and sex difference in terms of prevalence of suicidal outcomes. So first, parental support appears significantly more associated with suicidal thoughts in negative direction than is peer support, although both are significant. From a developmental perspective, this makes a lot of sense. Although parental and peer relationships are important for both preteens and teenagers, we tend to see a developmental shift in transition to adolescence, with peer relationships becoming increasingly important. As for sex differences in suicide, both suicidal thoughts and attempts appear to be more common among preteen girls than boys. But we see this flip in adolescence, with suicidation and suicide attempts becoming more common among girls. Of course, there's exception with suicide deaths, which are more common in boys across all age groups. That's more a function of males more likely to engage in more potentially lethal methods. If we come back to depression, we see an interesting similar pattern. Before adolescence, girls and boys are largely comparable in terms of risk for depression. But by the teenage years, a pronounced sex difference emerges with depression becoming more common among girls. Given the strong association between depression and suicide in these age groups, and a similar pattern of sex differences by developmental period for these two outcomes, a question that naturally follows is whether some of these processes that account for this shift towards greater prevalence for depression in teenage girls may similarly be at play in the case of suicide. I'll just end here with a brief example. So puberty has been implicated in risk for depression. Puberty typically starts early in girls. Very briefly, there's a lot of interest in different aspects of puberty, pubertal development in terms of timing and tempo. We know that early maturing girls relative to early maturing boys, for example, may be at greater risk for depression. The literature on puberty and suicide is much smaller, but we see some similarities so far with one recent study from the APC study finding advanced puberty in preteens being associated with suicidal thoughts and behaviors. I'll just end there and turn things back over to Mitch. Thank you.
Thank you so much for all these amazing presentations, really thought-provoking, and lots of questions that have come in. I'm going to throw some to you in a pretty much random order. The first is a question for Dr. Luby. Is there any evidence on whether expressions of suicidality in early childhood, between ages 3 to 7, for instance, might predict an elevated risk of ideation or attempts later in life? Do we have that kind of longitudinal data yet?
We do actually, and I should have mentioned that in our preschool depression study, where we followed the kids now into late adolescence and we're actually following them into early adulthood, we do see continuity of suicidality across development. That was published by Whalen et al. In JCAP several years back. So early signs of suicidality are a harbinger of later persistent ideation.
Wow, all the more important for us to be starting to look much more at these very, very young kids as you're doing. Another question for Dr. Brent. Since cannabis use rates are going down, could it be that kids who are using are outliers and it reflects something about emotional and social functioning, i.e. they're having greater difficulty and thus at greater risk for self-injurious thoughts and behaviors?
It's a great question. It's a bit fine-grained for the type of data that we're looking at, but there was one trend that in the YRBS that might be suggestive of that, which is that there was a spike. It's come down a little bit about kids vaping alone using cannabis. Whether that is enough to account for this relationship or not, I don't know.
Can I just follow up on that? One of the things that we've seen in our data is that kids are turning towards ways of regulating their emotions. And in a climate where there's less eating disorders, less substance use, suicide is just becoming an option that they can exercise more frequently, especially because they don't have to gain access to means in some cases that are as hard to gain access to as drugs might be, or something like that. Any thoughts about that?
I don't know. It sounds wrong, but I don't really have a good. I don't have a really good. I don't have a precise rejoinder to that.
Sure. No, fair enough. Dr. Sheftall, is there any evidence on whether exposure to racism is elevating the risk of suicidation or attempts within the Black and African American communities?
Yes, there's actually been a number of studies that have looked at racism, stereotypes, discrimination, specifically with Black youth. That is a risk factor that has been shown to be associated with suicidal behaviors. And it is something that we're continuing to explore in our research.
Do you think that some of the experiences that are happening now on a national scale and the ways that we're seeing kind of issues affecting minoritized communities could and might have kind of longer term effects on minoritized individuals who are seeing this kind of expressed at a systems level, especially in the last, let's say 9 months or so?
Unfortunately, there's been so many experiences that people have had with law enforcement, let's just say, good or bad, right? People have experienced relatives being taken away from them by ICE and other institutions. People have been losing their jobs. So there's been a lot of system-related factors that people have been experiencing that could absolutely have some long-term effects, but it is to be determined. We are looking at those experiences and noting those experiences and trying to figure out what they do potentially lead to. But longitudinally, we'll have to look at that data over time.
Thank you. A question that everyone can likely weigh in on, is there anything that you can share about LGBTQ plus youth, and particularly for youth who might have multiple marginalized identities, and how that might help us to understand some of the phenomena and trends that you're looking at as well?
I would say one thing is kids are coming out earlier. And I mean, it's good that people feel comfortable coming out, but I think um, it's possible that they're not as able to, not as cognitively facile in dealing with all the stress that may be associated with coming out. But other, you know, other than that, I'm not really sure.
And just to add to that, there is data from some sources, including, I believe, the YRBS, showing that the proportion of youth who identify as LGBT, at least, has been increasing over the years. So this is relevant to a great proportion of this age group.
So perhaps some minority stress that's being experienced within the LGBTQ plus population. It's interesting, Dr. Brent, you talk about social media. There are some kids who talk about social media as providing them with a benefit in connecting with other LGBT plus youth, but simultaneously are then also subjected to cyber hate that's directed towards themselves or members of the LGBT plus community overall. When you talk about social media, you were starting to get at, beyond just screen time, kind of some of the very specific experiences, and that was um, referencing some of the work that Jackie Nisi and Richard have worked on. Any thoughts about kind of the net positive, net negative that might be coming from social media, particularly for the LGBT plus community?
I mean, it's a double-edged sword. It's a good point. I would say that if surveys of sexual and gender minority youth in general, they are positively valenced towards social media. It's a safe space for them, and but it's difficult to parse that about their also the experience of cyber victimization.
Yeah, yeah. A question for everyone. Many schools and pediatricians use depression or suicide risk screeners. In fact, I think that was recently recommended by pediatrics, is that everyone should be getting screened. But kids are still falling through the cracks. What gaps do you see in our current screening tools, and how could they be improved to be more accurate and culturally sensitive?
I think one thing to note is that just because you're depressed doesn't necessarily mean that you're suicidal. And if you're suicidal, doesn't necessarily mean that you could have depression. So I think having depression screening only is not the best option when trying to look for suicidal behavior specifically, but also being very specific with your questioning. Like Dr. Luby indicated, kids as young as 3 understand the question. And they also, to make it very clear and not kind of beat around the bush, so to speak, so that you are getting the answers necessary in order to act and to take that preventative effort to make sure that that child is okay was really, really important.
Yeah. Any other thoughts about screening?
I mean, I think we need to generically reassure clinicians and primary care clinicians that asking these questions is important and that there's really not a danger in doing it.
Well,
Yep.
the main danger is that they find people and then they don't have anybody to refer them to, and so I think that's been a huge disincentive for pediatricians who are encouraged to find more cases, and then aren't able to then effectively arrange a disposition. It doesn't
Absolutely.
undercut what you're saying, but
Absolutely.
it's
Yeah,
a reality.
completely agree. Completely agree.
David, I think that that's an issue that comes up a lot. I'm glad that you raised it because not only are there a dearth of folks who are trained and able to work with suicidal youth, but there are a number of providers who simply don't want to work with suicidal youth. Maybe they don't feel they have the expertise, or maybe they feel that that's just, a very, very tough case to take. So in our research with acutely suicidal youth in Chapel Hill, there's a psychologist on every corner, but we can't find a referral for the kids who express a higher risk and need
Obviously, you send
follow-up.
them to Duke.
Right. No. So I do wonder, do you see a need within both the psychiatry and in psychology for, or even perhaps a compulsory kind of expectation that everyone is getting training on how to deal clinically with suicidal youth, and there's an ethical responsibility even to not turn away suicidal patients? Any thoughts about that?
Well, I would say, sure, it has to be part of our training, but I think what I would say is I think you need a team to treat suicidal kids. And so I think the issue is if you're a private practitioner, um, and you aren't part of a team, I think it's really, really hard to make a living and and have the support and expertise and judgment, that I think you need more of a network to really deal with these kind of kids.
I mean, along that line, I think, if we think about the healthcare system and the dearth of clinicians, conducting mental health services, you don't have to have MDs and PhDs, dealing with every mental health crisis. And there is an increasing trend towards training people in a very specific fashion, even bachelor's level clinicians that could be dealing with people at various phases in suicidality crises.
Great point. Other thoughts? Thoughts about how this might be particularly relevant within communities of color?
I think that is definitely a concern. Um, we have looked at some of the data in terms of just YRBS data, and we've noticed that we'll see increases in attempts, but we won't actually see increases in ideation, which is a big concern for Black youth specifically. And we're trying to figure out, are we asking the right questions? What questions should we be asking of Black youth? Is the actual trajectory the same in Black youth as it is in other youth, where there's a thought, a plan, and an action? Or is there something that's in the middle that we're missing? So I think we're still in, unfortunately, a space where we don't know the best questions to ask. And I think a number of my colleagues and myself are trying to figure out what are the best ways to ask questions so that we're getting the best answers.
Well, there are data I think from Matt Knox's work in the Army STARS program, that if you look at people that make a suicide attempt and have denied suicidal ideation, and you never know whether they had it and they didn't admit to it or they didn't have it at the time, they have all the other risk factors. And so I think what we're what depending on the setting, I think that we're probably overemphasizing ideation, and that there are a lot of other things that, ideation is something that may be occurring at that time or not. But if people have a history of maltreatment, have a mood disorder, have combined substance abuse, or that there are a lot of other things that set you up at suicidal risk.
Well, speaking of suicidal behavior without suicide ideation, I know of some research that's revealed that pattern within Native American populations of youth as well. And we do have a question for Dr. Sheftall, but really for anybody, if anyone has thoughts about why also we're seeing such high rates and increasing rates in the Native American population. Any thoughts?
So Native American youth have always had the highest rate of suicide deaths. Unfortunately, there's a lot of history I think that we can point to that can actually help us to answer some of those questions. Um, when you think the history of the country itself. And I think we, again, don't know the best ways to actually prevent suicidal behavior in this specific population of youth. There's a lot of great folks that are doing work with Native American populations, going to reservations and speaking with the leadership there. But again, it is a very slow process of trying to change that trajectory of those youth.
Joan, a few questions about really young kids, and I wanted to ask you a couple of them at once, if that's okay. First of all, can you say a little bit more about what suicide gestures or suicide desire is looking like in young kids and how that might be different? And the second is whether there's any evidence to suggest that introducing kids to the concept of an afterlife itself when they're young, if that in and itself could be a factor that raises the risk for suicide.
So I'll go to the second one first, because that's an interesting question, and I don't know of any data on that. I mean, it's an interesting idea and something to study, but I'm not aware of anybody who's looked at that. With regard to the first, it's a great question, and people always ask it because it is very difficult to imagine it. But some of the things that younger kids do will be to tie things around their neck. And squeeze. They also will, jump off of second-story balconies or threaten to jump off of second-story balconies. In addition to, using lethal objects like knives and things like that and wield them around. So those things certainly do happen. I mean, I do think that certainly the risk of death in a 4-year-old expressing suicidal ideation is going to be less than a 16-year-old, but it's not zero. And, there are completed suicides that I'm aware of in younger children. So the issue is sort of the signal to noise. However, just the behavior isn't noise, it's also signal. So that needs to be addressed. When you're in so much distress, even if you don't intend to kill yourself, if you engage in self-harming behaviors or threatening self-harming behaviors, that's highly maladaptive and needs to be addressed.
Thank you. David, a couple questions for you. One is whether you've considered physical activity. Thinking about levels of physical activity in correlation with suicide rate, might it be that more social media has led to more sedentary time and less physical activity has led to more depression? It's affected sleep quality. It's taken away the benefits of exercise, and that might be a factor as well.
Well, if I had 12 minutes instead of 10, I might have gotten to that. But I think I tried to allude to it insofar as I said that, sleep, obesity, low physical activity, they're all interrelated. And I do think so. And I think there's another thing is kids are not participating in sports and sports teams as much. There a lot of, physical activity is also correlated with social activity that's very pro-social. So I think all of those, I think it's a very good point.
Can I just add something along that line?
Please.
Because David brought up the issue of the social media signal, and everyone's very interested in that, and I think he reasonably said this might be overblown. However, and this particularly applies to younger children, engagement with social media replaces live interpersonal interaction, which is a really serious problem for a 3-year-old, 4-year-old, 5-year-old. I mean, even more so for a 12-month-old. And frankly, it's happening. Screen engagement is happening in those circumstances too. So I think the question might be more, what are you not getting in the live human world when you're constantly engaged in social, in a screen, with the screen?
Yeah, Joan, one of those factors that people have talked about is the idea that kids are not needing to sit and work through their emotions in a way that might require their own problem solving skills, right? And one of the questions that we have is whether problem solving skills may be relevant here in what we're seeing. Could there potentially be a link in a world where you can, post your daily hassles, immediately receive support in the form of likes or comments, taking away kids' developing ability to be able to cope with, think about, solicit support in creative ways, or even come up with solutions, individually. Maybe the connection to social media is a part of this, maybe not, but do folks have thoughts about problem solving skills within the communities and age groups that you're studying?
Well,
I think that's huge. Absolutely.
what I would say is that there have been studies that show that affirmation virtually is not as powerful as in-person affirmation, but negative experiences virtually are actually worse than they are in person. So I think you're kind of getting the worst of both worlds by if the more that your social world is virtual.
I think there's also a question if this is becoming increasingly relevant with, we have Chat GPT now, and lots of individuals can just go to there to ask for answers to their problems. So that could be a challenge in terms of developing critical thinking skills and independent problem solving. So, right now we have the generation that's becoming native to this. And so I do think this is increasingly a question worth considering.
I think not only problem solving in general, but problem solving when emotionally dysregulated. So thinking about what are those coping mechanisms that potentially people aren't learning when they are engaging with people, with other people, right? Classmates or what have you, that they may not be getting when they're on a virtual screen, virtual environment all the time. So if they are dysregulated, are they able to problem solve as well as they could if they're always engaging with people virtually versus in person?
There was just a big RCT about randomizing schools to no social access to phones during school or not, and they showed that the kids, I don't see anything about emotion, but the kids definitely, their performance at school was better.
We actually in New York, they passed a law that no smart devices can actually be in schools anymore. So we shall see what happens.
We just have time for one final question, and perhaps a good question to end on would be your concrete advice to clinicians who are listening on how to assess risk for suicide. What is a question or two that you would suggest people are asking if they're working with youth today?
Let's say if you have a kid who has suicidal ideation, I think one of the things you want to ask is, what's kept you from acting on it? Because I think the more that people have reasons for living, that's going to sustain them. If they can't give you a good answer to that, I think your worry should go up.
Great. Other suggestions?
One thing I think about is of the things that we do have empirical support for is means restriction. So asking, discrete matter about means, like they have thoughts, well, what have they thought of methods? And so they have access to those means. I think that would be one way to help with this question.
Great. Well, I want to thank each of you for your participation on this panel. These were absolutely fantastic presentations, really thought-provoking and really inspiring for both clinicians, but also for the next round of research. So thank you all so much. Thanks to everybody for your questions, and I'm going to turn it back over to Dr. Matthew Knox.